Thank you for joining us for tonight's educational webinar on shoulder instability. Tonight's speaker is Dr. Rodney Comisar, OrthoNeuro orthopedic surgeon. Dr. Comisar is a board-certified and fellowship-trained orthopedic surgeon who specializes in sports medicine-related injuries, offering a full spectrum of sports medicine surgery, including arthroscopy and minimally invasive procedures. Dr. Comisar's special areas of interest include ACL reconstruction, multiligamentous knee injuries and dislocations, shoulder instability and dislocations, rotator cuff injuries, and shoulder arthritis, including total shoulder replacement and reverse shoulder replacement. Please type your questions in the Q&A box below your screen, and Dr. Comisar will answer questions following his presentation. Dr. Comisar?
Thank you, Heather. Good evening. Welcome. I'm a sports medicine specialist at OrthoNeuro and at Ortho Alliance, focusing on problems of the knee and shoulder. Today, we're going to talk a little bit about shoulder instability. It's kind of timely. We tend to see a little uptick in this problem, specifically this time of year with the start of football season. So if you have questions, don't hesitate to reach out. I guess we'll do them at the end unless there's something that's pertinent, mid-talk, and Heather can stop me. So the shoulder is the most mobile large joint in the body. It's a ball and socket joint, but with that increased mobility comes the increased risk of injury, often in the sporting world, sometimes in the workplace, and certainly with motor vehicle and motorcycle accidents. So what is shoulder instability? Instability really refers to the separation of the joint. So you have this ball and socket joint, and an injury such as depicted in these two cases can lead to the ball it's no longer contained within the socket, but it's separated or disrupted, typically in an anterior or anterior-inferior direction. So how can you, when we talk about shoulder instability, there's a lot of different ways you can kind of describe it to patients or your peers. One is direction. We talk about anterior. That's the way when you hear people say, hey, I dislocated my shoulder, typically in a traumatic setting, like in football, I made an arm tackle. Typically the shoulder will go anteriorly or towards that's describing the ball part of the joint going forward from the socket. Typically also goes a little bit down and in, or anterior or inferior. Similarly, posterior dislocations occur, not quite as frequently. Often it can be more of a subtle type of subluxation, which we'll talk about. There's also multi-directional instability, which means, just as it sounds, it can go in multiple directions. So some people have some instability or laxity in their shoulder joint where actually the ball can go anteriorly, it can go posteriorly, and in some instances even inferiorly. But those typically represent a different patient type than the ones we were kind of initially speaking about, those traumatic shoulder instability cases in football. We also can describe it about degree. So if you look at the top figure, that shows the ball kind of contained within that socket, if you will, looking from above, whereas the bottom, or the type 3, refers to a dislocation where that ball is completely translated out of the socket, and in this case over the top or over the rim, if you will. Subluxation is kind of part of that spectrum of normal to dislocation, where more in the range of 2, where the ball can kind of slide up on the front edge or the back edge and then can drop back in either on its own or being kind of manipulated back into place by the patient or perhaps someone else on the scene. Mechanism of injury is another way we describe it. Hey, this happened traumatically. I fell, I took a blow to the shoulder, I had my arm kind of jerked out of place, or sometimes with a lifting situation. Alternatively, atraumatic instability is something that occurs, and that again can be more of those multi-directional instability patients where something lesser, like in activities of daily living, can cause a problem like that. I reached over and grabbed something off the shelf and felt my shoulder slip or sublux. So when I was in training, we try to break it down in one of these two groups, kind of categorizing these patients as what they call TUBs, which refer to a traumatic injury, typically unilateral, meaning the same one side or the other, your left or your right. A Bankart lesion, which we'll talk about more, refers to the type of injury sustained with the traumatic dislocation, and that often these patients went on to have surgery to correct their problem. And then Ambry is kind of the other end of the spectrum. Those are those atraumatic patients, multi-directional instability. Often it's bilateral, meaning they don't just have it on one side, they actually have it on both shoulders, which may speak to their kind of root of their problem being more like a tissue type problem or collagen disease. They're often treated with rehabilitation, more likely responsive to rehabilitation. Partly because that the results of surgery were not as traditionally effective or a little less predictable, if you will. And when surgery did occur, it was in the form of what's called an inferior capsular shift, starting with like an open surgery where you're kind of tightening the capsule or hemming your pants, if you will. And now we've transitioned to more arthroscopic techniques to do that. But unfortunately, not every patient fits neatly into one or the other of these categories. Sometimes there's a combination of the two. And that could be the challenge to kind of sort it out as to how they're best treated. So shoulder anatomy, looking at this outline on top here, it shows like kind of a ball and socket joint. So you're dealing with the humerus or the arm with a ball at the top called the humeral head. It articulates with the glenoid, which is the socket. The socket is basically the lateralmost aspect of the shoulder blade or scapula. You have the articular cartilage, which is like the shiny stuff on the end of a chicken bone that coats the head and the socket. The labrum cartilage, if you look at the bottom right, it's kind of the middle part, the pear is the glenoid or socket with cartilage on it. Then the other type of cartilage is the labrum, which is circumferential around that pear, if you will. And that kind of helps with stability. Now, there's a lining or capsule that surrounds the whole joint. And within that capsule that surrounds the socket, there are these little infoldings, or what become the ligaments, the glenohumeral ligaments. So say 2 o'clock, 3 o'clock, and 5 o'clock on that picture, as well as 8 o'clock. Those infoldings represent the ligaments. And then surrounding the whole joint is the rotator cuff, where it starts off as a muscle on the shoulder blade or scapula side. And as it comes laterally more towards the humerus, the muscle becomes tendon, and tendon's the connector to bone. And then lastly, your biceps tendon goes up in the front of the shoulder in a groove and then enters the joint, kind of splitting a couple of the rotator cuff tendons and inserting it at the top of the socket in kind of like a 12 o'clock position, which you can see in that diagram. So the labroligamentous anatomy is really critical in understanding instability and contributes to our ability to function normally with our shoulders. So again, we have that pair from the side on the right shoulder. So to the right is anterior. You see the biceps coming in at the 12 o'clock position. The labrum is like a bumper that goes around the socket, and you can see all the ligaments and capsule attached. The middle part, the sling that goes from like 5 to 8 o'clock, that's the inferior glenohumeral ligament complex. You look at the bottom right, so when the arm is at the side, it's relatively lax, but when you bring the arm into abduction or like a throwing, partially a throwing position, you can see it tensions those bands or that sling underneath. And if you roll up into a throwing position, it basically pulls the anterior band and brings it up to like the 2, 3 o'clock position. So it's really one of the primary restraints to anterior dislocation or translation of the shoulder. So often when that labrum gets torn with a dislocation, it also puts the ligaments on slack. Similarly, going more across the body or rotating the arm down into internal rotation, it will tension the more posterior band of that inferior glenohumeral ligament sling or complex. So the labrum, it's like a bumper or a chalk block. So if you can see the glenoid is pretty flat, you add the socket, you add the labrum on the sides surrounding the socket, kind of deepens the socket, so it helps with stability. And then it also serves as the attachment point for the ligaments, which is critical. You can see there's a clear size mismatch. Or I was describing to patients like a golf ball and a tee. So again, that mismatch leads to more instability in the shoulders, say, than in the hip, which is very constrained. The cup is much deeper. The ball fits nicely in there, and there's not nearly as much motion or dislocations in that case. So the mechanics or biomechanics, you have what we call your static stabilizers and your dynamic stabilizers. So your static stabilizers are the things that are just kind of there all the time. They don't really change. And that we'll speak to that in a minute. And those really work at extremes of motion. Like when you get up to like a throwing position, your arms extended, or making like an arm tackle where your arms extended. That's when your static stabilizers really are functioning. Your dynamic stabilizers conversely work in mid-range when you're kind of just have your arms functionally at your side or reaching out away from you. And they protect the shoulder or stabilize it in those positions. So your static restraints, we already briefly talked about the flat, bony anatomy of the socket. at the labrum, attach the capsule and ligaments. And the other thing, the joint actually, when it's closed or the capsule's intact, there's a negative intra-articular pressure, which also helps with the stability of the shoulder. Certainly when you have an injury, the ligaments get torn, the capsule gets disrupted, that can vent that negative pressure and then also contributes further to the instability problem. Dynamic restraints are your rotator cuff, what we term your scapulothoracic movement, meaning how your shoulder blade kind of moves on the back of your chest wall, essentially. And then the long head of the biceps also is felt to have a role. Certainly when we treat these patients, whether they're patients who are not having surgery or patients coming off surgery, we focus very much so on like the scapulothoracic movement and also on the rotator cuff. And that is what can hopefully protect the patient from further problems and get them back to a more normal function and lifestyle. So these patients present in a lot of different ways. We're going to focus primarily on the top problem, the anterior instability. That's often the patient that, hey, I made an arm tackle, my shoulder dislocated, I fell out of a tree or off a ladder, my shoulder popped out. It's pretty convincing. It's fairly obvious. They may notice a pop, they have pain. Sometimes the shoulder will go back in on its own, but sometimes it has to be reduced or manipulated either on site or in an emergency room setting. Posterior instability is a little more subtle. You can get frank dislocations posterior inferiorly with like an electrocution or seizure disorder, and that typically happens when their internal rotators of the shoulder kind of overpower the external rotators and kind of drive the shoulder almost out the back. More commonly, posterior instability is harder to diagnose because the symptoms are a little more vague. Your patient may complain of pain, weakness, feeling that its shoulder slips or subluxes. We see this a lot in like weightlifting, like the bench press, or in football where people are specifically linemen and linebackers, where they're kind of constantly catching or pushing off in front of them against the opponent, and they may sublux their shoulder as opposed to dislocating it. And lastly, the multi-directional instability patient can have any or all these complaints. Sometimes they're more vague. There can be some burning. There can be some numbness and tingling, almost more we think about nerve or neurologic type complaints in these cases because the nature of their instability is so different. So important questions we want to know. Are you right-handed or left-handed? Sometimes that can have relevance with respect to how you'll proceed from a treatment standpoint and the relative urgency of doing something, the type of work you do. Was there a traumatic injury? If it didn't just happen, if this is something that happened a while ago or it's been recurrent, are there certain provocative positions maybe that you avoid? You know, some people feel like I can't reach out in front of me or get up to a throwing position. That's often more anterior problems. And patients who have issues working in front of their body, lifting, that can be more indicative of a posterior problem. Have they had this happen before, either in this shoulder or the opposite shoulder? Do they ever actually have to have someone reduce their shoulder, meaning pop it back in place in an emergency room? Do they have to get sedated, or does it just pop in and out on its own? And also, what kind of treatment, if any, they've had can be helpful in determining what's going on, but also how to proceed. On exam, we do a typical shoulder exam, look at the patient, check their range of motion and strength. But coming down to instability, we really focus on a couple key areas. The classic test is what we call the apprehension test, which is viewed in the top middle where the guy's laying down. You kind of bring his arm out to like a 90-degree abducted position and slowly externally rotate his arm as if you're approximating a throwing position. Most patients with instability will stop you. They don't feel comfortable in that position. They may feel like, oh, my arm's going to come out, and it may make them a little queasy. You can do it sitting, but it's even more, a little bit more dangerous in the sense that if the patient lurches away from you, actually may pop them out. In the office, I've never done that, but I don't want to start. A load shift test, or back up to the apprehension. Actually, the second picture from the top middle, you can see he's kind of pushing back on the guy's humerus or upper arm. You can also do it by putting the hand over the front of the shoulder. And what that does is if the shoulder is tending to slide out the front anteriorly, pushing back on it actually will reduce it or give them a feeling of, okay, security, like this is okay, I can tolerate this position. And then sometimes if you take the hand off again, they feel like, whoa. So that's an apprehension and relocation test. The top right shows a load shift where the arm is at the side. In that position, those ligaments that we saw in those diagrams are relatively relaxed, and you can kind of see how far can I push the shoulder or the humeral head in this case, anteriorly and posteriorly, getting a sense of like the patient's translation or how much laxity they have. The jerk test in the bottom left is one more where focusing on posterior instability, where the arm is out to the side. And as you bring the arm across the body and pull back, sometimes the shoulder can kind of pop or sublux posteriorly. I used to be able to do that on my shoulder, right shoulder, but learned that wasn't a good idea, and ultimately did some strengthening, and I don't have that instability problem anymore, but I also don't lift weights or play football like I used to. Lastly, looking at those laxity patients, and those are certainly those multi-directional instability patients we talked about, but even any patient that comes in with instability, we kind of check that they have generalized laxity. And some of those indicators are that bottom right sequence of pictures is called a sulcus sign, where one, you have the arm at the side, then two, you pull down on the elbow, and you can kind of see there's an indentation in the front and the back of the shoulder. That's called a positive sulcus sign that shows there's some laxity or that negative intra-articular pressure or suction in the joint. And if you external rotate the elbow and do the same thing, or external rotate the shoulder rather and pull down the elbow, in a normal patient, that suction effect or that dimple is gone, whereas some patients who have laxity will have persistence of that laxity or that sign. And also just generalized laxity is assessed by looking to someone hyperextend at the elbow, at the fingers, at their thumb, and then their patella. Can you pop their, or, sublux or push their kneecap out? So what's the pathoanatomy? There's a lot of different things that can occur when there's a dislocation. I'm going to focus on a few just more common names that you may or may not be familiar with, so you can kind of talk the talk, so to speak. So most shoulder instability problems in young patients result in these anterolabral tears. So if you look at this, a right shoulder from the side, that tear, this Bankart lesion is what was coined probably a century ago by a guy that first described it. It's been termed an essential lesion, meaning often when you have that, it ultimately leads to surgery. We would describe it as looking from maybe 2:30 or 3 o'clock to the 6 o'clock position in this case, but certainly those tears can extend up higher or go around the backside as well. The Hill-Sachs lesion is something very common as well that occurs in many, but not all, anterior dislocations. You can see on the left and then on the right. So when the ball is translated, this is a right shoulder looking from above, and this is an anterior dislocation. You can see the little triangle of the Bankart or labral tear anteriorly that happens when the ball displaces, and you get this divot or ding in the back of the head from the hard surface of the bone, the glenoid or the socket. And that Hill-Sachs impaction fracture is certainly pathognomonic or very characteristic of a dislocation. You can see it on some x-rays. You'll see it on many MRIs. And of late, we've recognized increasingly its importance in certain patients with recurrent instability. And lastly, the bony Bankart fracture. So we talked about the Bankart lesion involving the labrum. Here's one where it involves not only the labrum, but you can see it actually kind of cracked into the bone a bit. And this actually is what Deshaun Watson experienced last year for the Browns. He got hurt at one point in a game, actually was able to finish the game. I think he played pretty well, but afterwards they evaluated him. They diagnosed him with a bony Bankart fracture, likely with some kind of separation or what have you, to the point where they felt like, yeah, he needed surgery right away, and they shut him down for the rest of the season. So in addition to that, you can certainly stretch out the ligaments and capsule, which is a little harder to define. In patients over 40, we see more rotator cuff tears instead of labrum tears, whereas the younger patients, 20s, 30s, Bankart tears or labral tears are approaching 100% in incidence. Some patients, similarly when they're older, they'll dislocate and they may fracture the tuberosity, which are like the bony nubs where the rotator cuff attach. So these bony lesions, we've recognized they can happen on the socket side, like we referenced with respect to the bony Bankart. They can also occur over time where the front of the socket almost gets pounded down. If you look at like the top right image, I'm not sure if you can see it because I can see my picture there, but in any case, the front of the labrum also can kind of, or the glenoid rather, can be pounded down with each dislocation event to the point where it's almost like a broken golf tee, where it makes it more difficult to keep the ball in the socket, irrespective of, what's going on with the soft tissues. And that impaction lesion, there was a study out of a military Institute, I believe it was like the East Coast, Rhode Island area, where they did a series of studied their dislocators, which is common in the cadets and such. They had a single dislocation can result in up to 7 to 22% bone loss, which seems like a lot. The more that T you take away, again, the harder it is to keep the ball on the T, if you will. And then more over time, we started to define what is enough bone to have, or what's, how much can you lose before it becomes a real significant problem. We'll talk more about that. Also, we talked about the glenoid side lesions. We have these humeral head lesions, or the Hill-Sachs impaction fracture as depicted in the bottom left. And depending on how big that gets and how close that gets away from the rotator cuff insertion or more towards the socket, the bigger that Hill-Sachs is, it can be termed engaging and sometimes also contribute more to instability. Whereas once upon a time, they were thought to be relatively benign lesions. More recently, there was a guy in Japan, Yamamoto, about 17 years ago, that started thinking about these bony problems and try to put it all together, where we didn't just think about the socket and just think about the ball part, but think about putting them together and what's the combined effect. And he came up with this concept of the glenoid track. And so in basic terms, lesions are on track if you have a small Hill-Sachs fracture, really no bone loss, and you can tolerate that. And that's considered an on-track lesion, and you can either operate or treat that patient conservatively. But once you get off track, and that can be if either that Hill-Sachs lesion gets really huge, as depicted on the third and the fourth. The third is really large. The fourth not as large, but then you take away some of the bone in the front of the socket, and it kind of multiplies that effect. And so suddenly those are considered off-track lesions, and they have to be treated a little differently, sometimes more aggressively, with sometimes multiple procedures at the same time to fix the problem. So we use imaging to help us with these bony issues. Certainly, if you dislocate your shoulder, you go to the ER, you get an x-ray, one, to show it's either out or now it's back in, but two, we're looking for the Hill-Sachs lesion. We're looking for like a bony Bankart fracture, but most importantly, just to make sure the shoulder is actually back in place. There's been a lot of litigation in emergency room settings of missed dislocations, particularly sometimes posterior dislocations are harder to see. And if they don't get the appropriate x-ray series, patients have been sent home with their shoulder dislocated for weeks at a time, and that's a real problem. Sometimes in this case, if you can't get that axillary view, that top right x-ray where it shows you up from above, it's either in or it's out. If you can't get that, or if the patient can't tolerate it, it's often good to get a CAT scan to definitively answer, is the shoulder back in place. MRI is used more for diagnosing those labrum tears, soft tissue lesions of the capsule, rotator cuff, etc. In some cases, they'll use arthrograms where they actually inject some dye, so it's felt to increase the sensitivity and specificity of the study. Gives you a more definitive diagnosis. It's probably most used, I would say, now for revision surgery for rotator cuffs, or more likely labrum surgery. Also in throwers, where some of the findings can be a little more subtle. It's not used routinely, with conventional MRI having gotten to be so good and detailed. Plus, it requires an injection, which is uncomfortable, and patients don't particularly love it. CAT scans are used less frequently in this setting, but they are used, one, to confirm the reduction, as we talked about in the first case, but also to look at the bone loss. So while the MRI, you can get a sense, hey, there's some bone missing or there's a fracture, the CT scan is more detailed, more focused for bone detail, as opposed to MRI is better for soft tissue. So if you have an issue and you have a case where you're unclear about the extent of the bone loss, you're concerned it may change your treatment, that's where we get CTs to kind of better estimate that percentage of bone loss, and which may change your algorithm a little bit. So treatment, acute injury, produce the shoulder, whether it's in the field or in an emergency room setting. Typically, we use a sling for comfort. It doesn't seem to matter how long you put someone in a sling, whether it's a week or a month or 3 months, other than it may indicate or may contribute to the stiffness. It doesn't seem to influence whether they're going to have a recurrent dislocation problem or recurrent instability problem. There have been some studies 25 years ago where they were suggesting in Asia about immobilizing the shoulder in external rotation. So instead of having kind of your arm in a sling with your hand on your abdomen, having your hand kind of point straight ahead or off to the side was thought to maybe bring the ligaments and labrum closer to the front of the socket, and maybe that some of that would heal or scar in. after some initial promising studies that suggested it was helpful. Some of that's been refuted, so that's not a practice that's typically used, or that I see. Certainly, it's somewhat awkward to mobilize a patient in that position as well. Typically, we'll start them on some exercises after a week or two, kind of coming out of the sling, dangling, going to therapy to help them get their range of motion, their strength back. Because in some cases, patients actually will get stiff after these dislocations. If it's something in season, you may be able to rehab the athlete where they get their range of motion and strength back, put them in a harness or brace and play sports, perhaps basketball if they subluxe. Football, certain positions are more amenable to this than others, because obviously if you have to be able to go up over your head to catch a ball, like such as a receiver, or defend as a corner, it's a little harder to play in a harness or a sling that might kind of limit how much your arm can kind of come up and out. Whereas if you're an offensive tackle, it's much more likely to be something you can do to complete the season than choose to treat your problem after the season. Surgical indications typically are the recurrent dislocator. So if it happens enough, patients tend to get sick of it and they're like, hey, I want to fix this. It might go from where it happens with traumatic injury in sport to where it happens with daily activities, or even at night in your sleep, which is not a pleasant thought. There is a push more for first-time dislocators to be at least be considered for early surgery, and we'll talk about why. And lastly, if you have a displaced bony Bankart fracture, likely, I'm assuming that's what Deshaun Watson had that led him to have the surgery last year, particularly on his throwing shoulder. So rehabilitation, whether we're doing after injury to avoid surgery, or if they're coming off surgery, we work on range of motion, both of the glenohumeral joint, but also the scapulothoracic movement, or how your shoulder blade kind of glides on the back of your chest wall. Like, those muscles are very important as stabilizers, because again, remember, as the scapula moves, at one end of the scapula is the glenoid or the socket. So that can affect the orientation of that joint and contribute or minimize the recurrence, instability, or subluxing. And we do our strengthening, which involves some of these maneuvers, like the top left, they call it a push-up plus, which really works the muscles around your scapula, your rhomboids to help, and your serratus anterior to help that stability. Rotator cuff is kind of a workhorse to protect the shoulder, especially in mid-range with daily activities, and then deltoid function as well. In some cases, we may try to do some sport-specific functional testing, progress them to more sport-specific activities. Can they do them? Do they hurt? Are they strong enough? There's no specific protocols like there are for ACLs, where we do a return to sport testing, but that may be something on the horizon that we need to consider, depending on the patient's sport. Are they a thrower, or a swimmer, or a volleyball player, versus just a collision athlete playing linebacker? So the first-time dislocator, it's often a young, active male involved in a contact or collision sport. We know there's a high incidence of labral tears in these patients, and in some series up to 100%, which means if you got that, it's not a matter of if, but when you're going to redislocate, particularly if you continue along the same line of activity. Early surgical intervention, the intent really is to minimize the risk of it happening again. And in doing so, minimize additional labral tearing, stretching of the capsule and ligaments. We don't want to create any more bone loss either on the glenoid or humeral side, because there's a negative impact to that. And also just damaging the joints. Might as well go in and they'll knock off chunks of the articular cartilage surface that you can't put back, or you can't get to heal. There's a meta-analysis, seems pretty intuitive. Recurrent dislocators have more Bankart and Hill-Sachs lesions, so certainly they happen at a fair incidence with a primary dislocation. But every time you dislocate, if you didn't have a Bankart, you often get one. Similarly, if you didn't have a Hill-Sachs, you get one. Or if you have those, they get maybe bigger and more extensive or involved. Similarly, another meta-analysis looked at early surgery or first-time dislocators, lower the recurrence rate or redislocation rate, which seems kind of making sense, and also lower the need for additional surgery. Return to sport was actually equal in their group. Overall, there was better patient satisfaction or outcome measures. Early on, it was equal, but long-term, those patients who had early surgery did better and were more happy with their shoulder, if you will. There is one relative contraindication to early surgery, And that may be the athlete who really isn't apprehensive. So they dislocate their shoulder, they have a labral tear, but you put them in, lay them down, and you bring them up into that abducted, external rotated position, and it doesn't really phase them. That may suggest that that patient has a little less damage to the labrum, ligament, capsule, etc. And they may be more apt to have a successful return to play in a harness or a brace without recurrences. Certainly if they go back, they try to play through it, it comes out again, then we typically shut them down. We don't want the story where they come in and say, oh yeah, I popped my shoulder out every game this year. That can be really problematic as far as dealing with them on the back end. So primary surgery, this slide used to be flipped. When I started it, things were more often done open, like an old-fashioned incision on the front of the shoulder, turned to Bankart surgery with or without suture anchors to repair the labrum and the capsule and ligaments. Sometimes there was some bone transfers done. Now the slides kind of flip, where the majority of this treatment is arthroscopic. The top right demonstrates repairing of the labrum, and in doing so, you kind of grab the capsule or ligaments as well, kind of like hemming your pants. There's something termed a remplissage, which I'm going to talk about in a minute, that is if you have a larger Hill-Sachs lesion, which is termed, quote, engaging, or you're fearful that that's contributing to the risk of recurrent instability. It also can be done in the face of some bone loss. And then the bone blocks, it's called a ladder J procedure, is one of several descriptions. If you look at the bottom right, so imagine that attritional bone loss, those dislocations where the front of the socket has kind of gotten pounded down. The bottom right serves to take a little block of the coracoid, which is the bone you see kind of cut off, and it's moved down and screwed onto the front of the socket. And that lengthens the socket, so it adds bone. It also has the short head of the biceps attached, and that can serve as like a sling to block dislocation when the arm's kind of up and out away from the body. So a lot of what we did open, we've now translated to doing arthroscopic. Typically in my hands and in most people's hands, that bone block procedure is done open, but there are some that are out there doing it arthroscopically as well, both in the US and Europe. The remplissage is a French word to describe to fill in. So if you look at these two pictures on top, so there's the ball sitting on top of the socket, but you have this huge Hill-Sachs lesion where it's almost ready to come out the front, and you have the labrum tear as well. Now, if it's big enough, it's turned to be an engaging Hill-Sachs lesion or an off-track lesion. Similarly, if you have a bunch of bone loss, that makes it even more likely to occur on the glenoid, or bone loss on the glenoid side, I should say. So the remplissage actually imbricates or tenodesis the posterior rotator cuff and capsule into that defect as depicted on the top right, in addition to fixing the labrum. And that keeps the head from kind of rolling forward, engaging. It also just doesn't allow the whole posterior aspect of the head to translate anteriorly as much as it otherwise would on the top left. Doesn't really alter the post-op rehab or my time in a sling, which is typically 4 weeks on these patients, unless there's a bony issue or we're trying to get some bone to heal. The only concern is some people have issues with this is that may lose extra rotation, particularly in a thrower. You might have to think twice about using this as a augment to your Bankart repair, as long as you don't put the anchor too medial or too much towards the glenoid. If you make it more lateral, it'll have a similar effect, but it may not restrict the motion as much. So this bone block transfer we talked about, you can use the coracoid. It's called a ladder J. It's also, if the ladder J is, or that bone block from the coracoid is not big enough to fill the bony defect, you can use either bone from the iliac crest, from the distal clavicle as just a block without the attached biceps, or what's commonly been used in the last 10, 15 years is distal tibial allograft. They did some anatomic studies and basically noted that the contour of the distal tibia had a similar surface or curvature as the glenoid. And so they'll take part of a distal tibial allograft or donor bone, cut it to the desired size, and you can use a much bigger piece of bone in that respect than if in the case if you had a tremendous amount of glenoid bone loss. Typically, these bone blocks are considered if you have more than 20 to 25% bone loss. Also, in like a revision or redo case, I had a football player who dislocated. We did surgery, fixed his labrum. He had no real bony issues that I could identify. 5 months out, he was wrestling with his brother and kind of pulled his shoulder out. So we went back and did a ladder J procedure on him, and he just got cleared to go back to football and basketball in about 5.5 months. In France, it's much more common. They use this like as a primary procedure as opposed to like the arthroscopic labrum repairs or Bankarts where you see in the States. It is an open surgery. There's something called the Instability Severity Index score, that helps kind of stratify risk. And that's the highest risk patients are under 20, like contact or collision sports, overhead activity, hyperlaxity, and a couple radiographic indicators. But basically, if you took our American high school football players, the majority of them that dislocate would kind of stratify into this high risk group. So if they were in France, Lyon, France, specifically with Boileau, they would get a primary lateral J procedure as opposed to a arthroscopic Bankart in some cases here. So it shows the practice of medicine is different, everywhere you go, and it's something that we're always evolving. But to back to the lateral J, they call it a triple sling effect. So one, you have the bone block that extends the glenoid, makes it longer, serve as like a bumper. Secondly, when you bring the arm up into the throwing position, the biceps kind of swings up and it's basically across the front of the joint. So it's like another bumper or blocker to keep that in. And lastly, the way this reconstruction is done, you retension or tighten the subscapularis and anterior capsule in a way that also will have an inhibitory effect against redislocating. There was a historical procedure called a Bristow where they use a smaller nub of that coracoid and just one screw, and now it's evolved to this more extensive procedure with a little more bone to extend the front of the glenoid. So post-op, typically in a sling 3 to 4 weeks with an arthroscopic Bankart procedure. If I'm doing a bone block, they go to 6 weeks. Adding a remplissage to either of those procedures doesn't really change the sling time. Typically, the patients will start pendulums kind of coming out of the sling and like letting their arm dangle within a week or two. Therapy will start somewhere in the 2 to 4 week range, depending on how loose they are and how aggressive you want to be stretching them. My lateral J patients probably start therapy in 10 to 14 days. Initially, it's passive range of motion where the therapist is moving them, followed by active assisted, where you kind of lift it with assistance of your other arm. And then ultimately active range of motion, trying to get close to full motion by 8 to 12 weeks. And sometimes that comes really fast in certain patients, and some patients have a hard time getting that range back, particularly like external rotation at their side or up, getting to this apprehension or throwing position. Hopefully they won't be apprehensive anymore after surgery. But the lateral J patients, where you limit their external rotation to 0 or just straight ahead, like with their hand on their abdomen going to straight ahead, but not past that with their elbow to side for the first 6 weeks, just to not put a lot of pressure on that bone block. Then they start strengthening, typically around 3 months, sometimes a little sooner than that. And then return to sport on average is 4 to 5 months. For contact or collision sports with the labrum repair, it's typically 6 months for football, basketball, hockey. Occasionally a lateral J, you can let them go back a little sooner because the redislocation rate is so low. And we have to still solve the whole back to sport functional testing problem. Some therapists probably do more of it than others. Some trainers will do it, but there's no consistent recommendation for that at this point, other than just being strong and being able to protect yourself. So what are the risk factors to have them redislocate or recurrent anterior instability after arthroscopic stabilization? Patient age. So young patients, like a lot of things, for those of you that have seen our ACL talks, the young patients have a higher incidence of ACL tears. Similarly, young patients in contact or collision sports, especially the males, higher dislocation rate. Their activity level, are they doing sports or, certain sports, golf, things like that, it's less of a risk. But it can happen. How many dislocations have they had? The more they've had, the more there's damage to the capsule and ligaments being stretched out, and also the bone loss issue that we keep talking about here. And so you can see the bone on the side. And this is when it was first described in around 2000, when people started recognizing, hey, maybe there's something to this bone issue in addition to just doing a perfect anterior labral repair. Croft published saying in 2007 that maybe these big bone lesions are a contraindication to arthroscopic instability surgery, which now is kind of something everybody is familiar with and is intuitive, but at the time it was thought, wow, this is kind of a revolutionary idea. Maybe if it's a redo or revision, you're not going to go back and do another anterior labral repair arthroscopically. Similar if they have thin tissue and not much to work with. Those hyperlax patients can be challenging to do if they've failed an anterior instability case. And then some patients have a voluntary component where they can actually like pull their shoulder out. And those are often multi-directional instability patients. Otherwise, patients, like I told you, I used to be able to sublux my shoulder posteriorly. If someone can do that, that's going to tear your repair up. And then seizure patients are another group that, you don't want to probably treat in that fashion. So the bone loss, Burkhardt was a famous arthroscopist back in 2000 with Joe De Beer from South Africa, and they described this inverted pair. So something no one really was aware of, but the bottom right picture and the central images, that's with the inverted pair. So basically that attritional bone loss of banging down the front of the glenoid to the point where you had a broken golf tee. And they identified 25% of bone loss as a problem. Since then, that number's gotten a lot smaller to know that, hey, you can have lesser amounts of bone loss and still have recurrent instability risk. And in some cases, even if your shoulder doesn't come out, you may not trust it. You may not be able to do what you want. It may not really be able to be there for you, so to speak. He also focused on the engaging Hill-Sachs lesion. So how do we address these? I don't want to beat this to death, but the bony Bankart, you can fix it with sutures like depicted on the bottom right. You can like loop suture around and kind of repair it with the labrum and the capsule. That's the most common way that I would treat it. If the piece is big enough, you can put some actually metal screws across it to secure it. On the glenoid bone loss side, if the bone loss is a little bit, as defined by like CT or that bottom left picture, between 13.5 and 20 to 25%, you might just add a remplissage to your interlabral repair. If the bone loss is bigger, that's when you're thinking Latarjet or iliac crest bone graft, distal tibial allograft. And then with the engaging Hill-Sachs, that's where you do the remplissage. So the natural history. So if patients had prior instability, athletes have 5 times more likelihood to experience subsequent instability if untreated. So not great odds. That's why the whole first-time dislocator getting surgery is kind of evolved. Recurrent dislocators, meaning patients who maybe say, hey, my shoulder's come out like 6 to 8 times over the last 10 years. We found that there's a higher incidence of those patients getting arthritis. Maybe 20 to 25% of them will develop arthritis to the point where they'll need an early shoulder replacement, which is something that is another reason why we don't want to neglect these dislocators. Early arthroscopic surgery in one series had a 7-time reduction in recurrence rate and a higher rate of return to sport. And then again, led to this idea of, hey, we need to get to these early on. So what are the results of these surgeries? Good objective, subjective results with modified open Bankart, the old-fashioned open surgery without significant bone loss, where recurrences might be like 3 to 5%. The long-term results of arthroscopic versus open repair or open labrum repairs has been favorable, leaning towards the open, having a little bit better result. But over time, we've become smarter about, okay, who can we treat arthroscopically? Okay, we throw out the patients with too much bone loss because they're going to fail much more frequently. How else can we be smarter with these patients? And over time, the arthroscopic recurrence rate has gotten into the single digits, like 8%. And in many ways, it has some appeal or is attractive both to surgeons and patients. And so that's been the preferred treatment in the US for quite some time. There are some patients or surgeons who will operate on their collision athletes, or say you took care of a college or a pro football team, you might still do some open Bankart surgery for primary dislocations. Lazaridis did a review in 2019, which showed higher patient-reported functions by adding a remplissage to their Bankarts. They weren't specific in like who got them and who didn't, but overall, as it became clear that maybe there's not a lot of downside, more and more people are adding that to their Bankarts to lower their redislocation rate. A primary Latarjet has a very low recurrence rate in some series, 0 dislocations, and good patient satisfaction. The cons are it's an open surgery. It's a little more technically challenging, so not everybody feels comfortable doing that surgery as opposed to like doing an arthroscopic Bankart. There's also some issues with the bone block healing or sometimes resorbing, and then it can lead to hardware complications if the screws back out or break, and you have to deal with that. But the results of arthroscopic surgery, as I said, have gotten better. They trail those of open surgery, but have kind of more closely approximate that of open Bankart surgery. And how we've been smarter, right? So earlier surgery, understanding the bone contribution, understanding the global nature, meaning sometimes they dislocate out the front, but their labrum tear may go up around the backside to like 6 to 9 o'clock, in addition to the 2 to 6 o'clock or go up to the top, what's called the superior labrum. So understanding it's not just a front or a back or an anterior posterior problem, but have to look at the whole shoulder and fix whatever is torn. The use of more anchors. There's some series that show if you use more than 3 or 3.4 anchors, those patients had lower recurrence than patients maybe they got 1 or 2 anchors in their labrum. Certainly adding the remplissage when the Hill-Sachs is large and engaging, and also being smarter about going back to sport, not letting someone just say, hey, I feel good at a couple months and going back. It seems like, and there's not a ton of science behind it, but most people that treat high-end athletes will make you wait 6 months to go back to a contact or collision sport, maybe a little bit quicker with some of the non-contact sports, but a little more time and seasoning of the repair and maybe building strength and endurance can help minimize the risks or problems of going back early. So the other results, a meta-analysis looking at a bunch of level 1 series like prospective randomized trials, higher recurrent instability rate of non-operatively treated first-time dislocators relative to surgery. So it kind of makes sense, like we talked about. Patients treated non-operatively more likely to need subsequent surgery, whereas the people that are already operated on are not less likely to get more surgery. And worse patient-reported outcome measures in the non-operative group. Another series with adding the remplissage to a standard Bankart in patients with less than 25% bone loss lowered the recurrence rate. Similarly, return to sport at the same or a higher level, which is what people desire, with a remplissage and less recurrences and less reoperations. And lastly, the scope and open bone block procedure significantly lowers the recurrent instability rate with critical or even less or subcritical bone loss, but less than maybe 13%. Just a brief, let me see what the time is here. Briefly, posterior instability, commonplace but less obvious. Similar arthroscopic treatment, treating the labrum and the capsule or ligamentous structures. The bone issues are less common, but they're also starting to become recognized on that side as maybe contributing to recurrence. Arthroscopic surgical repair is like the gold standard. The results have improved significantly with a high rate of return to sport. In some ways, the open posterior surgery is a little more challenging, and the results have been more mixed. Certainly, the recurrences are in the same group: the collision athletes, the males, also patients with high-level sports, and maybe if they have some underlying tissue laxity that can lead to stretching out and failure. Predisposing factors include glenoid retroversion, meaning we all have a little bit of a posterior slope of the socket, like tipped posteriorly, if you will. Some patients more than others, and that may lead to more posterior instability, as can bone loss. And there are arthroscopic and open bone block procedures for the posterior glenoid bone loss if needed. So again, what's that multi-directional instability patient characterized by excessive translation of multiple planes? Common in young athletes, there's often a female predominance to it. It's often just a capsular problem. These patients have instability, but you get an MRI and there's no labral tearing, no bone issues. Excuse me. May or may not reflect capsule laxity. If you do an arthrogram, you can kind of see it's really a big pouch, if you will, in the bottom of the shoulder. These patients are generally loose jointed or ligamenously lax. They may even have a component of Ehlers-Danlos, which is a condition that affects the body's collagen and leads to like hyperlaxity and hyperextensible joints. And again, these patients may be able to voluntarily reproduce their instability. These can be treated similarly with like a pin. Since there's no labrum tear, you can still repair the capsule and ligaments, like tightening it all circumferentially to the labrum and the glenoid. Typically limit the early motion, and I don't really let the therapist stretch these patients. I kind of let them stretch themselves to comfort so they don't like stretch it out too much. That's always a risk. You go much more slowly at recovering their motion and strengthening these patients, and their posture and periscapular muscles are critical in kind of how it inclines or orients the scapula and can give you a better outcome or result. So in summation, shoulder instability, often traumatic, primarily anteriorly, with a high incidence of labral tears. The patients over 40 seems to be the cutoff where we start to see more rotator cuff tears. Certainly a higher incidence of young patients that are high risk. More and more we are aware or beware of the associated injuries to the glenoid or the humeral head. Generally, they're surgical, especially early surgery for those young patients. the atraumatic subluxator or dislocator may be something you proceed much more cautiously with a lot more rehabilitation, because if they don't put the time in and rehab while there, they probably won't do well after surgery. They may in the short term, but then they'll often stretch out again. And again, the untreated shoulder instability can lead to arthritis, and that's something we don't want for our patients. So thank you. Hope that was helpful. I think Heather has a queue of some questions.
Yes, thank you, Dr. Comisar. The first question is, does TUBS always require surgery?
Not always, but I would say the majority of the time, especially if, if more and more we're getting MRIs early after the first episode. And then if they have a labrum tear, we tell them statistically you're at extreme high risk of recurrence. And so then it's more a matter of planning when, is it something where you're trying to finish a season, or are you going to just take care of the problem now, get ready for next year, so to speak?
Do all labral tears need repaired?
Not necessarily. Some, you see some incidentally on MRI, especially if they're not associated with any trauma, and they may be found as a finding on an MRI. Excuse me, especially like superior labrum tears or what's called slap lesions. That's something we see a lot. That's more at the top of the socket. It may have a role in instability in certain patients, but it also is something where there's a lot of variability in anatomy. And so my superior labrum might be different than yours versus somebody else. And so we kind of put it all together. Is it, are you symptomatic? Did you have a traumatic injury? And just really treat the patient more than just the MRI.
Does a shoulder dislocation always lead to arthritis?
Not necessarily. No, the statistics suggest like 20 to 25%. And that's basically taking patients who've had dislocations over time, and you follow them over decades and then kind of see down the road what percentage gets arthritis. And, now I'd say it's probably less common that you have dislocators that are untreated like that. So certainly requires a lot of time, and like a study that was done probably more historically than now. Now we may be looking more at studies that see what the incidence of arthritis is for someone who may be dislocated 20, 30, 40 years ago and had surgery. And then do they still wind up with arthritis? Is it something we can prevent, or maybe it's something that happens when, the die is cast when they have that first injury, and then from there, nothing matters and they're going to get it or they're not.
If my shoulder pops out regularly, do I need surgery?
If it pops out without, unintentionally, if you're doing things and it's something that might be considered, although you'll look at the cause. Is there any pathology like the labrum, or is it, if you're one of those multi-directional patients, you might not necessarily need surgery, but you might need to be evaluated and put on a therapy program, and then kind of home exercises that you kind of do for the long term to keep it from getting worse. It also depends on how much it affects them functionally. If it doesn't really bother you, I guess you can live with it, but there may be some risk involved. And then, certainly we discourage people, anyone that says, hey, I can pop it out myself, we tell them, please don't do that. That comes with a lot of, unintended consequences.
Can you play contact sports with shoulder instability?
Yeah, I mean, you'll see a lot of players, high school, college, pro levels, that have these harnesses that kind of are below their shoulder pads and their upper arm, and it kind of limits them. So some of those patients may have had old surgery and they're just wearing this for protection going forward. Some patients do it, they pop out, they recover for a couple of weeks. We put them in a harness or a sling, and it'll fit onto the shoulder pads or underneath. And in certain positions, you can complete the season. Now, some people find that, hey, I just can't do it. I tried and it doesn't feel right, or it hurts, or I can't defend my position or play my position. And then we say, fine. Or if you go back and they dislocate again, we tend to shut them down, because again, we don't want someone telling me, hey, I came in and it pops out like every game or every other game, because we know that by the time they get to us at the end of the season, they're at high risk for having bone loss issues. They may have torn the labrum more extensively. And then you start to worry about the joint too, where you start to beat up the joint and get cartilage damage. And that indeed does cause arthritis issues. So we try to individualize it. It's not for everybody. It can be tried, especially if you're a senior, but if you're a freshman, I might say, it's not worth it. Let's just operate, get you ready for next year and go on. But if you're a senior, you're trying to finish, we make attempts to work with them if everything else being, within reason, no bony Bankart fracture or that kind of thing.
Can you prevent instability with strengthening?
I think it can be helpful, especially if you're like a subluxer or if you're a multi-directional patient. I think ultimately these happen traumatically. So if your arm gets forced, if you fall down and your arm's extended, someone lands on the back of your shoulder, that's something you can't protect against. But certainly just being strong through the upper body and torso, it can help in some cases, but some of it is not, it really can't be avoided.
If you had a traumatic dislocation with a Bankart lesion and a Hill-Sachs a few years ago, but you still have some discomfort and weakness, could you be a surgical candidate, or should you just modify your activity?
Well, it kind of depends on your age. We try to evaluate and get a sense of what's your discomfort from? Is it from the weakness? Is it from, hopefully you're not getting any arthritis. Maybe the shoulder can be rehabbed from a strength standpoint. And because if you're not really unstable or apprehensive, then maybe you don't need it. Now, if you're younger, that probably doesn't apply. But if you're, happened when you're 20s and now you're 30s or 40s and your activities change, you may be okay. You may not need, to have your labrum impaired and the shoulder stabilized. You may just need some rehab. And it really kind of depends on what your symptoms are, what you do, and what you're trying to get back to. Because in many cases, as we get older, we're a lot less aggressive with doing surgery on these patients because they may be able to accommodate and work around it because they're not playing tackle football when they're in their 40s,
And our final question is, does weakness in your scapular stabilizers predispose athletes for dislocation?
I would say it can, and not so much, again, those traumatic anterior dislocators, but sometimes maybe your posterior subluxers, rehabbing the scapulothoracic musculature can make that less of a problem or make it go away. Similarly, those multi-directional patients, if they have abnormal scapulothoracic movement mechanics, that's kind of the hallmark or the foundation of treatment of those patients before you even get to dealing with the rotator cuff. And so it can help those patients. But again, it's for the contact collision sport like hockey, football, wrestling, probably isn't going to matter. Never hurts. But for those other issues, it can, sometimes take someone who's symptomatic and make them asymptomatic and let them get back to their desired activities.
Thank you, Dr. Comisar. Are there any additional questions? No more questions. Thank you very much for participating in tonight's webinar. Our next webinar will be held on October 3rd. Dr. Mark Kolich, hip and knee reconstructive surgeon, will be speaking. Enjoy the rest of your evening and good night.
Thanks, guys. Thanks for tuning in. Hope it was helpful.
Thank you.